All right, so we're going to finish today the physiology of the respiratory system, and then I'm going to do a little bit of a review over the stuff that we've already talked about, as you'll be taking the quiz this weekend. Make sure you've checked the announcements to look about information about that, amongst other things, if you have yet to do so. Okay, so last time we talked about the anatomy of the respiratory system. We talked about, I don't know where my other paper is. We talked about the different parts of it. We talked about the functions of it. In addition to that, we talked about specifically in depth the larynx, and we talked about the pathway of air through the respiratory system, and we talked about the different parts of the larynx. So we talked about the glottis, we talked about the true vocal cords and the false vocal cords that surround the glottis. We talked about the different types of cartilage relating with the larynx. And we talked about the epiglottis, how that stops things that shouldn't be passing through into your lungs from passing through into your lungs. So now let's go into the respiratory physiology of it all. We're going to talk about, first off, breathing. How you actually breathe. It's called inhalation or inspiration. You'll also hear it called inspiration, and exhalation or, exhalation. Inspiration. Same thing. Excuse me. Okay, so let's talk about inspiration. So as we talk about how breathing happens, you need to remember the idea of diffusion. So you learned diffusion in biology. We've also talked about it a couple of times in this class. But diffusion is moving molecules from a high concentration to a low concentration. It doesn't require energy. It's passive. It's a form of passive transport. And that is actually how gas exchange happens within the body. So not only in your lungs, but also in the actual, between the cells and the blood, okay? So let's talk about how that happens. So let's first talk about just breathing in general. Breathing is all about diffusion. It's all about concentrations. We're gonna be looking at the concentration of the atmosphere, and we're gonna be looking at the pressure concentration within the thoracic cavity or within the lungs. As we talk about this, we need to remember that there are a few different muscles that we discussed that contribute to your ability to breathe. Okay, we have the diaphragm, and we also have the intercostals, both the internal and external intercostals that sit in between the lungs, one layer on top of the other. Those are key in you breathing. Now, a lot of the time, people come in thinking, if they haven't heard about this before, that when we breathe, we're basically sucking in air and blowing out air. That's not actually how this happens. The way this happens is all about diffusion. So we need to, in order to breathe in, we need to get the concentration of the pressure concentration inside the lungs to be less than the concentration in the atmosphere, and then vice versa for breathing out, okay? So let's do this. So we're going to talk about inspiration or inhalation first. This word should not say concentration, it should say contraction. Typo. Okay. So the very first thing that's going to happen when you are starting to breathe in is the diaphragm is going to contract. Okay. If we look at a picture of, this is not the greatest picture, but we can see it, so we'll look at it here. You can see that this is the diaphragm relaxed. It's like a concave up look. When it's contracted, it actually contracts downward and flattens out. So a diaphragm contracted is a flat diaphragm. A diaphragm relaxed is this basically this concave. It kind of fits inside your lungs or inside your ribs. Okay, so contraction of the diaphragm is the first thing that happens. Okay, as that happens, the diaphragm contracts, it's going to flatten out, and it's basically creating the thoracic cavity to be longer. Okay, so it's lowering the floor of the thoracic cavity, which is increasing the vertical dimension of the thoracic cavity. It's making the thoracic cavity longer. Okay. The next thing that happens is that the external intercostals are going to contract. And the external intercostals are going to contract, and they're going to elevate your ribs up and out. So they're going to push the sternum in your ribs outward, making that your thoracic cavity is now also is larger this way. Diaphragm's making it larger this way. Okay, so we're making the thoracic cavity bigger. That's the whole idea of inhalation, is to make the thoracic cavity bigger. Okay, by making the thoracic cavity larger, if you've taken physics, you know that if you have a larger volume, it decreases the pressure. Okay, so we are increasing the volume of the thoracic cavity, which allows the lungs to spread out, which decreases the volume inside the lungs, which is called the intrapulmonary pressure. So, yeah. So these two actions, the diaphragm dropping down, the external intercostals pulling your ribs, elevating them out, we're creating a larger space, which is decreasing the pressure. So creating less intrapulmonary pressure. Okay. As the gases spread out in the increased space. So we have a larger space, so we have less pressure, decrease in the intrapulmonary pressure. So now the intrapulmonary pressure, the pressure inside your lungs, is less than the pressure outside your lungs. Okay, so, and that says that here, but I'm just going to write it here because I sometimes think this helps to see it this way. So the atmospheric pressure, the pressure outside the lungs, okay, is now greater than the intrapulmonary pressure. So high, low. Okay. We know based on, slide this down a little bit. We know based on diffusion that molecules move from a high to a low concentration. So by decreasing the pressure inside the lungs, we now have a pressure gradient, high to a low, which is going to allow air to move from the atmosphere into the lungs. And this is how we breathe in. Okay, so the core muscles with inspiration or inhalation is the external intercostal, are the external intercostals and the diaphragm. We also have some accessory muscles that help. They do less work. The sternocleidomastoid, it helps to elevate the sternum. Also the pectoralis minor helps to pull the ribs out also, but the majority of the work is being done by the external intercostals and the diaphragm. Okay, this is inhalation, also known as inspiration. Okay, now exhalation is going to be basically the reverse process. Okay, so the diaphragm is going to relax. Okay, as the diaphragm relaxes, we are now decreasing the vertical dimension of the thoracic cavity. So when it relaxes, it moves up. So we're making the thoracic cavity shorter. Okay, so that's the first thing that happens. Next, we have the internal intercostals are going to contract and pull the ribs back down. At the same time, the external intercostals are relaxing. Okay, so they relax, the internal intercostals contract, and they pull them down. I'm gonna kind of reword this because I don't necessarily like the way that it's worded. Because we have the internal intercostals contract, and the external intercostals relax, and the ribs are going to go back down, decreasing the width, basically the width of the thoracic cavity or the lung cavity, basically. Sorry, I'm supposed to say contract, but it doesn't look like it. Okay, so diaphragm relaxes, we're having a shorter thoracic cavity. The internal intercostals contract, the external intercostals relax, which makes your ribs fall back, decreasing basically the width of the thoracic cavity. So we're basically smashing the thoracic cavity back down to a smaller size. Once again, with physics, if you have a smaller volume, it increases the pressure. So as we decrease the volume of the lungs of the thoracic cavity, it's going to cause an increase in the pressure that's located within the lungs. As the gases are pressed together, it increases the pressure. So we're going to have an increase in intrapulmonary pressure as the gases are compressed into a smaller volume because of the smaller volume. Okay, now we have the opposite. So now we have this increased intrapulmonary pressure. The pressure inside our lungs is now greater than the atmospheric pressure. So now if I do this, atmospheric pressure is now less than the intrapulmonary pressure. We now have high to low. So air is going to move out of the lungs. Okay. So by decreasing the volume or the size, the space that is within the thoracic cavity, within the lungs, we are increasing the pressure. As the space decreases, the gases are all pushed together, which increases the pressure. So now the intrapulmonary pressure is high, the atmospheric pressure is low. Basic law of diffusion, molecules of air will move from a high concentration to a low concentration. That is how we exhale. Okay. All right. So usually expiration is effortless. Okay. Oh, well, let me actually, before we do that. So the core muscles for expiration are in the internal intercostals and the diaphragm. The accessory muscles are your abdominals. Okay. And also some back muscles like that are called your quadratus lumborum. Yeah. But that's just a side note. But that is why if you have ever had a really bad cough and you cough for like a really long time and you end up having like sore abs, that's because your abdominals actually contribute to expiration. So under normal circumstances, expiration is effortless. Okay, so when you breathe out, there's very little effort being put into it. Inspiration, because you have so many muscles contracting, it's an active process, but exhalation is a passive process. However, if you have damage to your lung tissue, or if you have narrowed respiratory passages through like asthma or COPD or like ARDS or pneumonia or bronchitis or anything that basically affects the ability for your lungs to push air smoothly, it can actually cause expiration to become forced. So meaning that's when your abdominal muscles and those back muscles actually get really involved, because you're actually having to push the air out, you're having to force the air out, versus normally when it's just a passive process. Okay. The last thing on here, if there's any reason, and there's a variety of things that can cause this, where the intrapulmonary pressure and the atmospheric pressure become equal, it will cause your lung to collapse. So there are things that can happen where you have damage to the pleural sacs around the lungs, or a hole in the chest, or a variety of different things can happen that cause the pressure to equal out, and then the lung will collapse. Like a tension pneumothorax. If you're wondering more about that, you can go ahead and look it up, or ask me later. But that is something that can happen, and it is fixable if it's fixed within a quick period of time. Okay, so that's breathing. While we're on that, I just want to show you this before we talk about respiration. So this is what's called spirometry reading. So spiro means breathing and meter is to measure. So this is when we measure your breathing. And there's some interesting information on this chart. Your tidal volume is what you breathe normally, just the amount of air you breathe in and out. You never fully breathe all the air out of your lungs, okay? So you have the ability to just breathe normal, but you also have the ability to breathe really deep, right? We can just breathe normal, we can also breathe out normally, and then once we're breathed out normally, we can continue to breathe out even further, right? You've all done that before, where you breathe out and then you can push out more air. So tidal volume is the amount of air we just normally breathe. We also have your inspiratory capacity, so that's how much you can actually breathe in. Then you also have it the other way, how much you can breathe out with that reserve volume you can see on both sides, here and here. That would be the amount that you can, if you push, either breathe in or breathe out, okay? The total amount, if you were to breathe in as deeply as you can and then breathe out until you can't breathe out anymore, that's called your vital capacity, and that's showing you right here. Okay, that's what that is. Like I said, your total lung capacity is greater than your vital capacity. You always have a residual volume of air in your lungs so that your lung doesn't collapse on itself unless there's an issue, clearly. But there's always some air left in the lungs. So I would take a look at this and just kind of become familiar with it. There will be a couple of questions about like tidal volume and vital capacity on the quiz. All right. Two more things. We're going to talk about internal, external respiration, and then just a couple of conditions, and then we'll be done here. So when we think about respiration, we think about just breathing, okay? And that is part of respiration. If you've taken biology, you've also heard of cellular respiration. It's also known as internal respiration. But respiration is basically just an exchange of gases. That's what it is. Respiration is an exchange of gases. So this happens in two different ways: externally, which would happen in the lungs, so between the environment and the lungs, and then internally between the cells and the blood. So we'll talk about both of those. But before we talk about that, we need to talk about how gas is actually transported in the blood. Okay, oxygen. We talked about this in the last unit. It attaches to hemoglobin. If you remember, we talked about the hemoglobin and how each hemoglobin has 4 parts that each have iron, and then that's where oxygen attaches. So each hemoglobin can hold 4 oxygen molecules, and there are multiple hemoglobin on every erythrocyte. So they attach to hemoglobin on the red blood cells or the erythrocytes, okay? And a very small amount of oxygen is dissolved in the plasma, but the majority of oxygen is transported on the red blood cells. Carbon dioxide is different. Once oxygen has been attached, there's not room for carbon dioxide to really be attached to the hemoglobin. So carbon dioxide is a little bit bigger. And so actually what happens is carbon dioxide gets dissolved in the plasma. So it's dissolved in the plasma. And it's dissolved in plasma as a bicarbonate ion, which is HCO3 negative. That's bicarbonate ion. But that's how the majority of carbon dioxide is actually transported. It's transported as a dissolved ion in the plasma. Once it gets to your lungs, it will then be converted back into carbon dioxide, which you will then breathe out. okay? But the majority of it is dissolved in the plasma. This is also why if you have too much, like if you're not bringing enough oxygen, you have too much carbon dioxide in your blood, it can greatly affect your blood pH because of the bicarbonate ion that you have this buildup of, it's called hypercapnia, where you have too much carbon dioxide in your blood, which can actually affect your blood pH. And when your blood pH is affected, it can affect all of your organs, so it can be bad. Okay, but we know that red blood oxygen is mostly attached to the red blood cells. Carbon dioxide is transported in the plasma. So I'm going to draw this out. We're going to try to go through this a little bit quickly. This is a pretty simple process. This is once again diffusion that's happening here in respiration. Respiration is just the exchange of gases. So external respiration is the exchange of gases between the lungs, specifically the alveoli, and the blood. So I'm going to create, here's a capillary. Should have drawn that a little bit bigger, but that's okay. Here's a capillary. Okay. Located in this capillary, we have red blood cells. Okay. We also, if this is coming back to our lungs, so let me draw some alveoli here. Remember, alveoli are 1 layer thick, capillaries are 1 layer thick, which allows for molecules to diffuse pretty quickly because they're only having to pass over two cell layers thick. Okay, you've just breathed in, which means that you have high levels of oxygen in your alveoli. Okay, high levels of oxygen in the alveoli. High levels. Okay. In the blood is returning to the lungs. We know it returns to the lungs via the pulmonary artery. That's going to have high levels of carbon dioxide. It's been dissolved. So we have HCO3, high levels of HCO3 located in the plasma. Okay. High to low concentration. Get a different color here. We have high levels of oxygen here. We have low levels of oxygen here. So oxygen is going to diffuse directly into the blood. Okay. We have high levels of bicarbonate ion here. We have low levels of bicarbonate ion here. So bicarbonate ion is going to diffuse, and as it does so, it's going to turn back into carbon dioxide from the high to the low concentration. This is called external respiration. Okay. Internal respiration happens at the cellular level. So this is the exchange between the blood and the tissue cells. So let's get our capillary drawn here. You see what I'm drawing? Yeah, get there. We're going to have our red blood cells. Okay, we're going to have high levels of oxygen on our red blood cells. Okay, high levels of oxygen here. We're then going to have our body cells. I'm going to just draw some cuboidal cells here. You can draw whatever kind of cell you like. Cell membrane there. Okay. As our cells do cellular respiration, they're taking oxygen and they're converting it into ATP. They're also converting it into carbon dioxide. So we're now going to have a high concentration of CO2 within our cells. We have a high concentration of oxygen in our blood. So high levels here, low levels here. Okay. Gas exchange is going to happen through diffusion. We have low levels here. This is going to diffuse across, and it's going to be converted into HCO3. It's going to be dissolved into HCO3. And then our oxygen is going to go into the cells as high to a low concentration also there. So this is internal respiration. So it's the same process, it's just happening the opposite direction between the blood and the cells. Okay, so that's respiration. We know that oxygen is transported on the hemoglobin. We know that carbon dioxide is dissolved in the plasma as bicarbonate ion. And we've now discussed how exchange happens between the blood and the alveoli and how exchange happens between the blood and the cells of the body. All right, last thing we need to talk about are a couple of disorders. That deal with this system here, the respiratory system here. And looking for one paper, which I don't think I have. Don't have it, so that's okay. We'll just put it. Okay, so the first one here talks about destruction of the alveolar wall. So if you remember, last time we talked about how the alveoli, if you were to take the alveoli and spread them out, they would make up like 1/3 to 1/2 of a tennis court. So it's a huge surface area. You have this massive surface area that allows for lots of gas exchange to happen. So what happens if we destroy the alveolar walls? We now have less surface area, okay? This is caused by usually toxins of some form, whether it be toxins from smoking or toxins from exhaust or whatever it may be. But this causes destruction of the alveolar wall, which decreases your ability to get enough oxygen. Because there's not enough places, there's not enough surface area for the oxygen to exchange places. Excuse me. This is actually one of the leading causes of respiratory deaths in the United States is emphysema. Emphysema can also lead to COPD, chronic obstructive pulmonary disease, or, which is usually the final steps of emphysema. COPD is a combination of emphysema and like chronic pneumonia, basically, or like bronchitis. And basically the lungs are no longer functioning properly, and all the tubes leading to the lungs are all damaged also. They can be scarred or whatever it is, so they're more narrow. And so the people, whoever has COPD, they're just not getting the oxygen they need, and they're not being able to get rid of the carbon dioxide, which can lead to death. All right, a type of cancer, lung cancer. It develops in the walls of the bronchial tree, so all the bronchioles get cancer and get tumors in them, which makes it very hard to breathe. Unfortunately, lung cancer is one of the cancers that's very hard to treat and so the prognosis is not very good. When somebody's been diagnosed with lung cancer, the likelihood that they will die from it is very high. It is usually associated with, like it says, inhalation of pollutants, and that usually comes from smoking or secondhand smoke. Okay, infection in the lungs, which prevents gas exchange. This can be caused by bacteria or viruses. It's more often bacteria than viruses, or it can also be caused by aspiration of fluid, means that you breathe in fluid, and it can cause gas exchange. It will stop the gas exchange from happening. You've maybe had this, you know someone who has it. It's called pneumonia. Okay, there is a condition, sudden infant death syndrome, also known as SIDS. It's a mystery killer. Basically, it will happen before the baby is 6 or 7 months old, and the parent will go in to get the baby up in the morning, and the baby has passed away. We don't know what causes it exactly. There are a variety of theories. There's one theory that it talks about here on the paper about how maybe the carotid artery, which is the artery that leads from the heart to the brain, gets compressed when the baby's sleeping in a certain way, and then they're not getting oxygen to their brain, and it causes the death, but that we don't actually know what causes SIDS. There are some some risk factors that can increase the chance. Smoking is actually one of them if the mother smokes, not the baby. If the mother smokes, then it can actually increase the likelihood of SIDS from happening. It's not common, but it's not uncommon also. At some point in your life, you will know someone who has had a baby die from SIDS. I know a couple of people who have had babies that die from SIDS. And it's sad, and there's no reason that it happens. It's just a perfectly healthy child, doesn't wake up. And they're doing research into that currently. Okay, next one is a bacterial infection of the lungs. And it says it's characterized by pulmonary infiltrates. If you look at an x-ray of the lungs, pulmonary infiltrates, you can actually see them. It's basically stuff in the lungs that shouldn't be there. This can cause like severe breathing problems. It's called tuberculosis. It is not super common in first world countries, but it is more common in like third world countries. It is treatable. Yeah. Okay, last one. This is an allergic response characterized by bronchial spasm. So the bronchioles within the lungs spasm and constrict and become smaller. So it's like taking a straw and putting it in your mouth and then trying to run, only breathing through the straw. It makes it very hard to breathe. This can be caused by an allergic reaction to something. It can also be like an autoimmune type issue where it's not really autoimmune, it's kind of autoimmune, where you have it all the time. But people who have like an allergy to nuts, if they eat nuts, one of the responses is that they won't be able to breathe. But this isn't actually like a condition where they have it all the time. This is asthma. Different things can affect asthma. You can get it at different times in your life. You can also, certain types of asthma you can get over. There's something called activity-induced asthma, where you only have asthma when you're exercising. It's more common in kids, and you generally grow out of it. Other people with asthma have it their entire lives. Someone who has asthma, they'll use an inhaler. And what an inhaler is steroids that will dilate the bronchioles. So the issue is the bronchioles are spasming, so they take the steroid, and the steroid helps to relax the bronchioles back out to their full size to stop the reaction from happening. All right, that's the whole thing. Make sure that you have read the directions on how to take the test. I can't find what I'm looking for. Hold on a sec. Here it is. All right, do the two of you on here have any questions?